Bismillahirrahmanirrahim. I'm very thankful to DOCTORSCON for inviting me on this prestigious forum to give talk, and thankful to our worthy colleagues, Professor Yusuf Kamal and other co-chairs to be here early this morning to chair this session, and thank you all the audience as well. So today what we are going to talk about is sodium glucose co-transporter inhibitor, because as earlier has been mentioned by Chairperson Professor Yusuf Kamal and Professor Fuad Randhawa, diabetes is not about just controlling the diabetes, controlling the glucose reading. It's more than that, because if you look back, I would say the very first landmark point when when the paradigm shifted was back in 2006, when the DREAM trial came out and we saw the blood glucose improved with rosiglitazone, but at the same time there was higher incidence of MI in patients with rosiglitazone. Then again, we saw replay of that in a CORD trial, where we controlled HbA1c more effectively, but not realizing how we are controlling, what drugs we are using, we ended up with a higher mortality in those patients, even though with controlled diabetes. So the new, the shift in management of diabetes is not just about regulating the glucose, but it's lowering their risk for cardiovascular disease and using those agents for the right kind of setup and for right kind of indications. We are very blessed to be in a time when there are so many drugs already out there, and there are a lot more in the pipeline as well, which are not only helpful for management of diabetes, for management of, but for reducing the cardiovascular complication and complications from diabetes as well. And sodium glucose co-transporter inhibitor is one of those agents. And I will go through in my coming slides briefly to show you what kind of data we have with this group of drugs. So why we should be using SGLT2 inhibitors, mechanism of action, primary benefit, empagliflozin, few trials I will highlight, and then what were the secondary benefits of those trials. Sodium glucose co-transporters, we all know these are in the renal proximal tubules type 2. And if you look at, at this slide, do we have a laser? Sodium, glucose and sodium gets absorbed from the luminal side into the epithelial cells of the tubules and then gets goes back in the circulation. So there's a lot of glucose which goes which gets secreted into the tubules and gets reabsorbed back into the system. And we'll come to the percentage of that. But if you look at many drugs which are available, most of those drugs, they work through insulin-dependent mechanisms where either they're insulin sensitizers, or they help release insulin like sulfonylureas and others, or replace insulin. But sodium glucose co-transporter are one of those drugs which do have mechanisms independent of insulin reserves of the body, insulin production capacity of the body as well. So glucose homeostasis, earlier I mentioned, contributes up to 20% of the gluconeogenesis in patients postprandially from the kidneys comes from that. 10% of total body glucose utilization is through this mechanism, and filters and absorbs about 180 gram of glucose per day from the kidneys. So imagine if 180 gram of glucose, we let it be excreted in the urine, we are depriving that, decreasing that caloric availability of that person times 4. That comes out to be 720 kilocalories per day. We are reducing those calories by this mechanism if we block this absorption in the proximal tubules, where 90% of the glucose is absorbed back into the blood circulation. There are sodium glucose co-transporter type 1 channels where only 10% is absorbed in the distal part as well. So there are many unique things with patients with diabetes. In patients with diabetes, this is the normal system, but we know that if the filtered glucose is glucose body load is more than 180, then extra glucose gets absorbed. But when it comes to diabetes, there is more to it. it's not the renal threshold we keep reading all the time in patients with diabetes, but of 180, but that renal threshold drops significantly in these patients. They tend to, glucose tends to go into the circulation with this, but then the tubules which are absorbing it, they are far more active. And this is one of those studies published in Diabetes back in 2006, where the transport protein expression, the ability of these cells in the proximal tubules to absorb glucose in patients, it's an overexpression of that, these channels in the kidneys. If you look at these healthy subjects, if the normalized level is this much, we tend to see much higher level of expression of these transporter proteins in the proximal tubules in these patients for the SGLT2 and for the GLUT as well. So there tends to be more absorption of glucose, tends to be more absorption of sodium in the proximal tubules, and cellular glucose uptake, the same thing. Those expressions, they get increased in patients with type 2 diabetes. What that means? What this means is any amount of glucose which goes into the tubules, there is a higher absorption, higher degree of absorption of that glucose from the proximal tubules back to the circulation in diabetic patients compared with the healthy subjects. So empagliflozin, one of the very big landmark trial, EMPA-REG trial, came around 2015. And I think this was one of the major trials, earlier major trials, which showed how these drugs can be very effective, not only by controlling diabetes, but reducing the cardiovascular risk factors. In 2006, when the DREAM trial came out, FDA actually got caught off guard. They got burned because they were approving drugs which were actually causing higher incidence of cardiovascular disease. So after 2006, they said every drug for diabetes which comes to the market has to show that it is neutral, at least neutral from cardiovascular standpoint. It does not hurt, it does not increase the complications from cardiovascular perspective before we approve this for diabetes. And many trials came out at that time, and they had to show that it does not increase the risk for cardiovascular complications. But EMPA-REG trial, which came with empagliflozin, is one of the landmarks, but that not only it showed it's neutral, but it showed there's more benefit to that. And then we saw more trial leader came out, and then multitude of trials which have come out mostly with these two group of drugs, sodium glucose cotransporter inhibitors and glucagon-like peptides, GLP-1 analogs. Of course, these drugs, they do help to improve the HbA1c, as you can see, compared with placebo and compared with its competitors. There is improvement in HbA1c. I will go through these slides very quickly because purpose of, we all know these drugs control HbA1c, but I want to highlight other aspects of these drugs aside from just the glucose control. Fasting glucose gets improved significantly when you compare these drugs with the placebo or even with their competitors. This is green is empagliflozin, and the orange is the sitagliptin comparison. So EMPA-REG trial, when it came out, it was a landmark because it changed the paradigm shift. So sodium glucose, we learned sodium glucose cotransporter inhibitors are not only glucose-uric, but also reduce the development and progression of heart failure and prolong life of patients with type 2 diabetes and reduced ejection fraction as well. That was the first limb of that. So major paradigm shift with affecting the clinical practice. Then came the EMPEROR-REDUCE trial, where we learned that sodium glucose SGLT2 inhibitors improve outcome in patients with reduced ejection fraction with or without diabetes. So this is a drug which is very, very in high demand with the cardiologist as well. It's a standard of care to prescribe this drug in patients with the heart failure, whether that's with a preserved ejection fraction or reduced ejection fraction, regardless of the fact if these patients have diabetes or not. So that was a big paradigm shift. Then came the EMPEROR-PRESERVE trial, where we saw the benefit in patients with in heart failure with preserved ejection fraction. And above all, the EMPA-KIDNEY trial came out. Sodium glucose cotransporter inhibitors slow the development of end-stage kidney disease in patients with CKD, benefits of these drugs in patients with or without diabetes. So earlier I said for cardiologist, if patient has heart failure, it's a standard of care to give these drugs to those patients regardless of diabetes. The same thing applies for kidneys also. It's beneficial, and we will come to, in coming slides, we will see how these drugs benefit both for the heart and for the kidneys as well. It was a huge trial of 7,020 patients randomized, and 3-point MACE and 4-point MACE were both part of the primary and secondary outcome in these patients. And very briefly, the heart failure, hospitalization, or cardiovascular death, you can see with empagliflozin improved significantly compared with the conventional treatment group. And heart failure, hospitalization plus or cardiovascular death, that also improved significantly with EMPA-10 and EMPA-25 compared with placebo. There were fewer mortality in these patients. For 3 years in 1,000 patients with type 2 diabetes high risk, we saved 25 lives, 82 versus 57 deaths in this group, fewer cardiovascular deaths, and fewer hospitalization. Now, let me just take you back to the historical perspective. This was a pre-statin era. At that time, when we started using statin in patients, we learned that if you treat 30 patients for 5.4 years, you will save 1 life. With the HOPE trial, with the Ramipril, we saw if you treat 56 patients for 5 years, high-risk patients, you will save 1 life with that. But with these newer group of drugs, we learned just for treating 3 years, 39 patients, we are saving 1 person's life. So if you look at the total number of diabetics in Pakistan, 34 million approximately, and you calculate that if you're treating those patients with these drugs, especially the high-risk ones, you are reducing at least more than 500,000 deaths over 3 years period. So such is the importance of these group of drugs. So EMPEROR reduced trial this was done in patients with reduced ejection fraction, and the cutoff was less than 20% with or without diabetes both. And in these trials, these were the endpoints. I will not take you into the nitty-gritty of these trials, but this was the final outcome. The reduced EMPEROR trial, we saw significant statistical improvement in patients who are on empagliflozin compared with the conventional treatment group in terms of risk for hospitalization from heart failure, and in terms of death from heart failure as well. And then came the EMPEROR Preserve trial. This was done primarily in patients with or without diabetes who had ejection fraction above 50%, and they did have heart failure with preserved ejection fraction. So in these patients also, let me skip some slides here. In these patients, we also saw the composite of cardiovascular death or heart failure for hospitalization was significantly better in patients with empagliflozin and placebo, compared with placebo, sorry. So empagliflozin reduced first and recurrent heart failure by 27% in a confirmatory secondary endpoint as well, about a relative risk reduction of about 27% here. So how does these drugs work? What are the different mechanisms of actions that they are able to give us these effects not only for glucose control, but beyond glucose control, protecting the heart, helping the weight loss, and reducing the oxidative stress. So, I mean, this is a very busy slide, but through the mechanisms, the reduced ATP production in the kidneys, because remember, when these sodium glucose co-transporter channels, they have to absorb glucose, there's a lot of ATP required in those channels, in those cells to absorb glucose. So that ATP is conserved within the cells, and that what it does is it reduces the risk for relative hypoxia by providing those cells with enough energy there. So reversion of myofibroblast to erythrofibroblasts, producing fibroblasts, increase in hematocrit, and then increased glucagon to insulin ratio, which does help to cause lipolysis. Glucose-urea helps to do the weight loss as well, increase diuresis through the kidneys and reduce plasma volume and improve endothelial dysfunction. It does help to improve the ventricular loading conditions as well, preload as well as the afterload. So these are some conventional mechanisms, but then we know that there's a lot more to that. If you go into the molecular mechanisms in there, it autophagy induction. It improves the autophagy for the damaged cells, for the damaged organelles within the cells as well. And this way it reduces the oxidative stress and endothelial dysfunction, which improves the cardiovascular outcome in these patients. So that's another part. Improved cardiac ionic hemostasis. I would urge you guys to read on this because I'm just highlighting, it's difficult to cover all this in 20 minutes, but just some highlighting different mechanisms, what we have seen so far in these patients, improved myocardial energetics through this cascade of events. It leads to, at the end of the day, the outcome is improved cardiovascular outcome in these patients. So there are multitude of, like, if you ask me, 10 different mechanisms through which these drugs, they are beneficial and they're helpful there. In terms of kidneys, earlier I talked about it reduces the progression of end-stage kidney disease, and also EMPA reduction in albuminuria, 32% reduction in microalbuminuria versus placebo, and 41% reduction in microalbuminuria with placebo. And we all know patients with kidney disease who are albuminuria, micro or macro, that's an independent risk factor for cardiovascular disease. So this is also addressing another independent risk factors there. And renal, yeah, we have gone through this, what is the data there. So, I mean, it's just not the EMPA-REG. We have seen multitude of trials. Credence, we have saw DAPA. With DAPA, we saw in DECLARE trials, we have seen this. And other SCORE trials we saw. It's across the board. We have seen all these benefits, cardiovascular benefits in these patients with sodium glucose co-transporter inhibitors. So this is the cumulative meta-analysis of all those trials comparing with others, and the mechanisms we already have discussed in detail earlier. Yeah, so getting out of cardiovascular disease now, we are talking about the fatty liver disease. Drugs are very helpful in fatty liver disease because all the data we have seen, the newer name for fatty liver disease is metabolic associated steatotic liver disease. So MASLD, we have seen improvement in these patients who are with SGLT2 inhibitor. It has not gotten the indication yet, but there is data out there. More trials are coming out, and my guess is just a matter of time before we get indication of these drugs for MASLD as well. So all these trials have been, sorry, I've been going. So, I mean, if you look at the guidelines which have been published in past few years after lifestyle intervention, the role is for metformin for patients with heart failure or CKD. We want to jump to SG, sodium glucose co-transporter inhibitor, and for patients who have risk for atherosclerotic cardiovascular disease, in there we want to go to GLP-1 analogs first before we go on there. But if the cost, affordability, and side effect is the issue, then SGLT2 inhibitors, they are the drugs to go with. Now, I don't know how many of you reviewed the guidelines from ADA from 24. In 24, ADA has gone out on one limb to say if your patient is newly diagnosed type 2 diabetic patient and the patient does have history of kidney disease and heart failure, you don't necessarily have to go through different jumps like metformin and then the dapagliflozin. Those patients need to be given, or empagliflozin, those patients need to be given sodium glucose co-transporter inhibitor even as a first-line drug. So the newer guidelines have given the option that if your patient, you feel like has to be only one drug and history of CKD and heart failure, you put those patients on sodium glucose co-transporter inhibitor even before introducing metformin. So that's an optional thing which ADA has recommended, but still most of us, the standard recommendation has been you go with metformin and then you add the second agent in these subset group of patients there with heart failure, with CKD, or with atherosclerotic cardiovascular disease patients. ASCVD is only after using GLP-1 log, you come to SGLT inhibitors. So this is more detailed form of those guidelines, what I mentioned earlier. So there's a triple protection for a broad range of patients with this type 2 diabetes and cardiovascular disease, reduction in the risk of the 3-point MACE events, heart failure. We have seen reduction with that. CKD, we have seen reduction progression to kidney disease. I'm on my 20th minute, so I have a few more seconds, so I will see how much another 1 or 2 slides I will run by. So not only we have the better glycemic control, we have better renal effects, we have better cardiovascular effect with these group of drugs. I will not go into the individual details. This is my last slide, which summarizes it. Increased glucose reabsorption may contribute to hyperglycemia and diabetes. That's like a physiological change which happens in diabetic patients. So that's why these drugs are very helpful in this population. Inhibiting renal sodium glucose co-transporters induces glycosuria with lower blood glucose and help in weight loss. Empagliflozin or dapagliflozin or others drugs from this group reduce HbA1c, reduce the weight, reduce blood pressure in type 2 diabetes with low risk for hypoglycemia. Earlier, Professor Fuad mentioned how disastrous can be hypoglycemia in these patients, especially when if they have cardiovascular disease or CKD along with that. So these drugs have cardiac and renal protective effects as well as a beneficial effect in terms of dementia and metabolic liver disease as well. I missed that dementia slide just to save some time. Adverse effects of UTI and GTI and GI are not severe and respond to the standard therapy in these patients. With this, I will thank you very much for your attentive listening.